So to start, my name is Stephanie Baker. I'm a QI manager with the iPro QIN-QIO, and I'll be your facilitator for today's events. So we really want to make today's session as interactive as possible. We want to utilize the chat, and we're also going to be utilizing the polling feature. So to get us started, we really want to know who's on the webinar with us today, what organization you're with, where you're located, so what state or city, since I know we do have a lot of individuals from all different states, and what is your role in reducing utilization at your organization? And then we want to start with testing out our polling with a very simple poll question. So Ryan, if you can launch that, perfect. What is your care setting that you are calling in from today? Go ahead and answer that. And we'll give it just a second because I know people are busy chatting in and also polling. All right. I'll give it one more minute. We'll get one more person in there. There we go. Perfect. All right. So it looks like we have acute care hospitals and critical access hospitals joining us today. I do know too in the registration, we had a number of individuals from ambulatory care settings, home health agencies, and some government agencies. So we're excited to have you today with us. All right, so we'll go ahead and get started. To start, we're going to just review what the structure of this 9-session series will be. We'll define complex care and multi-visit patients. We'll talk about reviewing your data and look at an assignment that we have for you after the session today. And then we'll go to an open forum where we'll have a chance to ask questions. And also we have some questions for you as well. So as I said, this is a 9-session series, and our hope is at the end of the 9-session series, you will be able to identify individuals at high risk by using internal methods such as population, health data, and known drivers of utilization. You'll be able to recognize individuals who have had multiple hospital visits, and you'll be able to map and develop a process and interventions to assist in meeting the needs of those identified patients. So we hope to cover this throughout the different sessions that we'll cover through February, I believe. And during this time, we have some learning activities that we would really like to engage you in. We really want you to conduct a deep dive into your data to see if methods used to identify multi-visit patients are effective. We want you to assess how communication of risk is shared with your team members. We want you to apply an internal management process to identify multi-visit patients. Is it, via EHR, direct screening, or interdisciplinary rounds? We want you to share the population data and utilization drivers across the teams, and then pilot a process to use specific interventions for those patients you've identified. This is the overall schedule of our 9-session series. Today is our launch, so welcome and thank you for joining us. In December, we'll have a small learning circle, and the learning circles are typically 30 minutes, and they'll really be more interactive. So it'll be a chance for individuals to ask questions, talk about any barriers or challenges that you may be having, and share some of your results if you would like. Then we'll have some LAN events. So those are more of our hour-long sessions where we'll talk about screening, referral, and closing the loop. We'll also talk about understanding and addressing drivers of complex care. And then our last session will be a wrap-up and to celebrate, all that we've learned throughout this series. The link there is actually a link to direct you to all the different schedule of events. So you can click on that link. Josh will put it into the chat and you'll be able to register for all the upcoming sessions. So for today, the goal of today is to really set the stage and get us thinking about complex care. We really want you to be able to define complex care in multi-visit patients, analyze your data to identify who your multi-visit patients are and the reasons they're returning to the hospital and from what care setting, and to identify your initial key team members to support your high-risk patient needs. This session is, really, again, it's going to be pretty basic in setting the stage. And as we go along in the series, our hope is to really advance in the information that we're giving to you, but we also really want you to help inform what we cover in the next coming sessions. And without further ado, I'd like to introduce our speaker today. Dr. Garner is a senior medical scientist at Health Centric Advisors. She's an associate professor of medicine at the Warren Albert Medical School of Brown University and a practicing internist at Rhode Island Hospital. These roles have really enabled her to combine clinical experience with the implementation and evaluation of healthcare quality improvement interventions and policy. Dr. Gardner, I will now turn it over to you.
Thank you, Stephanie. Great, so I wanted to start this afternoon with a patient story, and I wanted to tell you about the case of a 65-year-old gentleman with a history of alcohol use disorder, depression, atrial fibrillation, and heart failure, who was just admitted to your hospital with a heart failure exacerbation. Now, his hospital course ends up being complicated by alcohol withdrawal and AFib with RVR. And looking over his chart, you see that he's had more than 6 ED visits and hospital admissions over the past year. So this is a complex patient and he needs complex care. What is complex care? It can be defined in a number of different ways. I like how the Camden Coalition describes it as a person-centered approach to addressing needs and improving health that focuses on people with complicated medical, behavioral, and social challenges that end up resulting in extreme patterns of utilization and cost. At its best, complex care is person-centered, where the individual's goals and preferences guide all aspects of care, and the care delivery is designed around that whole person. It's also cross-sector, working at the system level to break down silos and to promote collaboration. At its best, it's team-based, delivered through interprofessional and sometimes non-traditional teams that can include peers, community health workers, and hopefully the patient themselves. And it's data-driven. So accurate data are used to identify individuals with complex needs who are at high risk, and also data are used to effectively meet their needs and to evaluate the success of any program. And finally, and most importantly, it's equitable. So it addresses the consequences of systemic issues like poverty and racism, and individuals and their communities are partners in developing the solutions. In the words of this director of integrated care management, complex care can bring together entities from across the healthcare ecosystem to address barriers at multiple levels, and therefore have a better chance of being able to succeed in caring for a very high need population. And these barriers are both personal and systemic. What is meant by healthcare ecosystem? Well, I really like the schema from the Blueprint for Complex Care because it shows so many different factors that are at play when we care for really any patient, but particularly complex patients. We see the usual domains of physical and behavioral health, and those are at 1 and 2 o'clock on your screens. But this schema also brings in social issues like housing, food, transportation. And then at 9 o'clock, you can see it includes the criminal justice system, which is such an important part of the health consequences of our patients' lives. Complex care patients are multi-visit patients. Now, here's how we define multi-patient. And by we, I'm referring to the QIO and Medicare specifically. For Medicare, they are Medicare beneficiaries. They have 4 or more admissions or a combined total of more than 5 ED visits, observation stays, and admissions over the past year. Now, your organization may and probably does use a different name to describe this kind of patient and probably has a slightly different definition.
So we would like to launch our next poll, and we want to see if you've heard the term multi-visit patient before. All right, seems like a good mix of, it's going good. All right, we'll get one more in. One more. All right, so it looks like a good mix of yes and no's. And next, what we want to do, I'm just going to share these results or stop sharing, is hear from you. How are you defining your multi-visit patients in your organization? And by what term do you typically refer to them as? Are they super utilizers or do you use a different terminology? So if you could take a minute to chat that in, and I'm going to ask Josh if he sees anything in the chat that he could share.
Hey, Steph. So far, we're seeing them being referred to as high utilizers.
Great. All right, I will turn it back over to you, Rebecca.
Thank you. So back to our case, as you recall from the beginning, this is a 65-year-old gentleman who has multiple comorbidities. He comes in with a heart failure exacerbation, has a complicated hospital course, and he has more than 6 ED visits and hospital admissions over the past year. So he definitely is a multi-visit patient or a high utilizer patient. It sounds like a lot of y'all label these folks as. And this is, he meets by Medicare's definition, but I would imagine for most of your organizations, he probably meets criteria with y'all as well.
So we, like we said, we wanted to keep this interactive as possible. So what do you think are some reasons patients are returning to the emergency department multiple times? So you could take a second to chat that in, and then I'll ask Josh to share anything that he sees in chat.
Sure. So far, what we're seeing is lack of PCP availability, behavioral health diagnoses, no primary care or availability there, housing deserts, lack of medical resources, non-compliance, low health literacy, distrust.
That's great. Thank you for sharing.
So with all the reasons that y'all have just put in the chat and many more, it will not be a surprise for anyone to learn that for most organizations, their multi-visit or high utilizer patients make up a high proportion of their overall utilization. The slide you see in front of you shows local data from before the pandemic. And you can see that multi-visit patients are only 4% of the patient population, but they drive more than half of the readmissions. And this may be true in your organization as well. I think it would be helpful to think about contributing factors in 3 large categories: medical, social, and behavioral. And you all have come up with examples in each of these. So for medical, as many of y'all said, and to add to that, it can be conditions that are quite hard to self-manage at times, like diabetes, or medications that require constant monitoring, like warfarin, or debilitating conditions like end-stage COPD. For social factors, you've mentioned a lot of them. It can be lack of support, lack of social support. So assisting with doctor's visits, having someone to advocate for the patient and someone to encourage and get them to follow up. For the patient and their caregivers being able to speak, read, or write the dominant language where they're being cared for. Lack of insurance, or maybe they have insurance, but under insurance where they can't afford the copays. And for behavioral conditions, things like mood disorders and psychotic disorders, which make adhering to a treatment plan very difficult, as do things like substance use disorders. All of these are incredibly common, and it sounds like are major issues with your own patient population. So let's think about our patient and his medical factors. He has the medical comorbidities that you see in front of you, along with access, difficulty managing his medications. His social factors include the fact that he has quite an unstable housing situation and lives on his friend's couch in the evenings, but kind of is on his own during the day. And he also has difficulties accessing food. Behavioral factors for this patient include depression and alcohol use disorder, both of which are quite active right now, and neither is in remission or treated. Now that we've had a chance to define complex care, to think about what goes into a multi-visit patient, what the definition of that might be. And we thought of the reasons why patients might be needing to use the ED so frequently. I'd like to turn at this point to identifying multi-visit patients or high utilizer patients in your own practice settings, as many of y'all already seem to be doing, and how you might be able to analyze and interpret the data that may be available to you.
All right, so we'll launch our next poll. Does your organization currently have a method to track your multi-visit patients or your high utilizers? And I'm seeing a few yeses come in. We'd love to hear what tracking methods you're currently using. And if you could chat that in as well.
So Stephanie, so what we're seeing so far for that are spreadsheets, claims, utilizing emergency room and inpatient data, complex care department tracking the EHR discharges. We're also seeing alerts from CarePort and Allscripts. Michelle shared we have a readmission report in Epic. Also, Quality does a daily tracker.
Great. All great methods for tracking your data. And so for those of you, and those of you don't know, do you know who on your team is reviewing that data?
So Russ says he is, and Sherilyn shares that she does know who is reviewing the data.
Great.
Michelle also shares that she's also doing it as well.
All right. Sounds like we have a lot of individuals on this call who are doing the review of the data themselves. I'll turn it back over to you, Dr. Gardner.
Thank you. So when exploring the processes that are going on in your own organization, it can be helpful to ask yourself a few questions. And first, does your facility or organization actually have a method, number one, to identify these patients? And then once you've identified, how do you track them? How do you track patients who have multiple visits and complex care needs? And we've seen a couple of options right here in the chat, including readmission reports, ADT notifications that are coming to you from hospitals, and then claims, whether they're from Medicare or any other payer. Another question to ask is then who reviews the data when you do get it? How often are folks looking at it? Do they share it with anybody else? How frequently do they share it? And it sounds like we have a mix here on the line, including folks who have the good fortune to work with a quality group. This will likely be individuals working for larger organizations. Then we have case or care managers. And then in smaller organizations, sometimes it's a lone nurse or social worker who does this along with a lot of other job tasks. And certainly each organization needs to figure out who are the stakeholders, who needs to see these data and how frequently in order to act on it and make a difference. And then finally asking, what are the triggers that might prompt me to look to see if the patient in front of me is a multi-visit patient? And it might be that the patient has identified food or housing instability. Perhaps they have a substance use disorder or a behavioral health diagnosis, or maybe they have multiple complex chronic conditions. Any one of these might prompt me to look to see if the patient has higher than expected utilization, to see if I need to start addressing some of these concerns, even if this weren't a patient that might necessarily have been on my radar before. So as you think about your organization's internal processes, I think it would be helpful to have in mind some resources that can be used to improve utilization. And there have been many described for multiple different settings, but we wanted to review a few of some of the more evidence-based models right now. So we'll start with the hospital setting and Project Boost, which is developed by the Society for Hospital Medicine. We know that this intervention reduces preventable readmissions and improves workflow for folks on the inpatient side. They have a focus on medication reconciliation and admission, and particularly at discharge, in an effort to reduce medication errors, which may be a reason why folks are coming back to the hospital. And importantly, it prepares patients and their families to be able to care for themselves after hospital discharge as they transition back into the community. Like most meaningful interventions, it requires us to understand what the current barriers are, and to be willing to adapt, and also to secure institutional commitment. Another resource developed for hospitals is Project RED. Now, this was developed in the hospital setting up at BU, but since then it's been successfully adapted for use in skilled nursing facilities, especially when when nursing homes are looking to discharge patients from their short stay back into their community care. It's also been shown to reduce readmissions, and it improves patient satisfaction with hospital care. And we know it works in diverse populations because that's the very population in which it was developed and tested. And it involves multiple different components, which can be done separately, but are really intended to be done together because they are mutually reinforcing. And like Project Boost, you can see that it also requires an understanding of current barriers, a willingness to adapt, and institutional commitment. Moving on to other resources for nursing homes, anyone who works in the nursing home setting is probably familiar with Interact. It was originally developed to reduce acute care transfers, meaning when a nursing home has to send a patient back to the hospital for evaluation and management of a change in the patient's or the resident's condition. And it has tools that help frontline workers identify, evaluate, and hopefully at some point manage those changes in the resident condition to prevent them from escalating to the point where the patient or the resident does need to be transferred back to the hospital. These tools also help with communication when a nurse might need to contact, say, a covering physician at the nursing home to communicate their concerns about the resident. How can they both best organize and communicate in a way that allows the covering physician to have a sense of what's going on and to feel confident making a plan to manage the patient in the nursing home setting and not send them in. One of their newer focuses has been on advanced care planning, and I know that somebody in the chat mentioned that that's an important aspect, especially in our older, sicker patients. And the idea would be that if advanced care planning was tackled in a less acute setting, then perhaps the patient wouldn't need transition to an acute care setting at all, and perhaps end of life wishes, if that's where things are, could be managed fully outside of the hospital. And as you probably won't be surprised to hear, this too requires the exact same commitment on behalf of the organization, like all the other intensive interventions. Finally, for community settings, we certainly like the work of the Camden Coalition, which uses healthcare hotspotting, and it provides very intensive community-based care management. The data are mixed in terms of whether or not they reduce readmissions in all populations, but they've certainly demonstrated reduced readmissions in some populations. And one thing that is certain is that they are able to link patients to primary care in social services. I know a number of y'all mentioned lack of access to primary care, or even if the patient does have a primary care physician, being able to get in a timely fashion is a real barrier. So this is a focus of this group of folks. And the final bullet here is exactly the same as on the previous slides, because unfortunately, anytime we do a major intervention to create lasting change, it requires all of these things. So at this point, we've discussed how folks might go about exploring the processes in their own organizations and some resources that people might be interested in trying. But I wanted to now think about how to identify root causes for folks who do have high utilization. Once you've identified who these multi-visit patients are, kind of what do you do next? What's the next step? The first thing is to identify a multidisciplinary team when that is possible and your organization allows for that. It sounds like several of you are on a multidisciplinary team, but some of you might be kind of flying solo. But bringing in folks who have different perspectives and different skill sets can be extraordinarily useful when taking a deeper dive, and certainly is a lot more fun. Step 2 would be to say, okay, let's pick at least five of our multi-visit patients, and then try to look more carefully and define the problem more clearly. Which care setting do these folks tend to be coming from? What prompted them to seek care in the emergency department? And after you have a sense of who they are and why they're coming in, discussing how different interventions might help your particular patient's needs. Bringing this back to our patient case, I think it's a good opportunity to think about how we get to the root cause and how to sort of define that problem more clearly. One way to do this is to keep asking the question why. So when a problem presents itself, ask why, and then ask why again. And again until you reach the root cause. So for our patient, maybe our preliminary question is, why was this patient admitted to the hospital? Well, the simple answer would be he had a heart failure exacerbation, but we don't want to stop there. So we ask why. And it turns out that he is really not able to take his meds or to consistently adhere to the diet that's been recommended to him. But we don't stop again and we ask why. Well, he has that difficult housing situation where he just basically has access to his friend's couch at night. And so he doesn't really have a place to store or cook his own food, which means he's eating prepared food, which is quite high in salt. We ask why else. And because he is out on the streets most of the day, he has limited bathroom access. And so he's afraid to take that diuretic he needs for his heart failure and risk an episode of incontinence, which would be a disaster for him. And so he's really afraid to take his diuretic unless he is in a place where he has easy access to a bathroom. And finally, we might ask ourselves, why doesn't he have a kitchen and a bathroom of his own? Well, it turns out our gentleman here has past criminal justice involvement, which makes it difficult for him to secure a job and an apartment. So with that, Stephanie, I will hand it back over to you to start the open forum portion.
All right, great. Thank you all. So now we would like to open it up for discussion. And so the first question that I have, we talked about the importance of looking at your data to identify those multi-visit patients or high utilizers. What do you think will be a challenge to you? Because I know all the organizations are different in getting their data from different places. What might be some of your challenges? And if we have a brave soul who would like to come off mute, I definitely welcome you to do that. I'll give it a second. I'll even stop the share so we can see everyone who's on the call. Is there anything in chat? Thank you, Russ. So Russ is engaging them at the site before they leave the ER. Sorry, Josh.
Yeah, no worries.
I think that's a great point. That's how that's proven to be a very effective model for folks with substance use disorders, connecting them to a peer recovery person right in the emergency department, who then can follow up with them as they make their way back into the community. That's a great idea.
Any other challenges? Thank you, Sherilyn. So hospitals don't have interacting communication. Could you elaborate on that, Angie?
Oh, sure. Well, different hospitals have different products that they use for documentation. So what happens in our place is that they scan things over to us, but a lot of times, well, no, not sometimes, that doesn't happen. So we don't get the nuances that we need to identify those patients.
Thank you, Kate. Any thoughts?
I put the question in chat again, just since it was taken down. What will be the biggest challenge in looking at your data and finding out the reasons patients are returning to the hospital? So in case anyone missed the question, I put it in chat again.
This is Mary Jameson, Holyoke Medical Center. I think with our data, we're able to figure out why patients are returning to the hospital. I think a challenge is communicating with the patient after discharge. They might not have a telephone number, or they're just difficult to make contact with. So keeping them from coming back again can be a challenge regarding communication.
Yeah. Agree. Has anyone found any good solutions for that and contacting the patient after discharge? If their phone's not in service, they've changed numbers. I know I experienced that a lot in a past role.
Hi, this is Kiri from Holyoke Medical Center. I'm one of the nurse navigators. So we've tried to figure out some unique ways to interact with patients if we're not able to get a hold of them by phone. So whether that's mailing them a letter if we think we have a reliable address, or trying to catch them at an appointment. So we have access to see a lot of different specialty offices as well as our primary care office. So even if a patient doesn't have a phone or it's not working, we're able to get creative and kind of engage with them at the next appointment if they attend.
It's a great solution. Thank you for sharing that.
Do you physically go to that appointment, or do you try to call in to the office and engage with them over the phone? I'm curious how you deploy your staff.
So we actually have nurse navigators and community health workers embedded in our primary care practices. So it's a big collaboratory effort, and we're actually able to physically go to those appointments and meet with them.
That's great. Really tapping into your community resources, really using your community-based organizations. A number of them do have community health workers or social workers that will, reach out directly to the patient. They'll go to the home to connect with the patient, to find additional information and help them with their appointments. So really using that kind of that scheme that we had at the beginning, where using the whole community to care for these patients. Any other thoughts? And Russ, it looks like you mentioned coordinating with community mental health and medical providers. I hate to put you on the spot. Do you have any examples?
Well, we actually have a ED diversion program, and we have 2 case managers who actually go out into the community, meet with the individuals, whether it be at the ED or in the community, and coordinating the care with the medical and mental health providers. Not always an easy thing. Some providers are easier to communicate with and others not so much, but because we're an insurer, we kind of have an in, so it makes it a little bit easier.
Agreed. Any other questions before we move on to our challenges or solutions, before we move on to the next question?
Seth, before you move on, probably worth noting for those who are participants from Massachusetts, and the Elder Affairs currently has a grant opportunity for Massachusetts-based hospitals to partner with aging access points, so community-based services, to increase that hospital to home process, which potentially could help your with complex care. If you're interested and you did not know about that, please reach out to Stephanie or myself, and we're more than happy to send you the information. They're looking for 10 awardees, and I believe that the application is due in early December, but we'd be happy to help you with that.
Thank you, Lynn. Yes, definitely a great opportunity. All right, so our next question is, what are you hoping to gain from attending the next few sessions? So like I said at the beginning, this opening this opening session, whatever it's called, educational event, we have different terms for different things, is really to kind of set the stage for what we want to go over in the next few sessions. And you can help inform what we bring to the table. We really want to start bringing in, some best practices, bringing in some organizations that are doing well at working with their multi-visit patients. So please tell us, what interests you most. Sometimes I wish I had Jeopardy music during these times. What are some challenges that you might be seeing, and do you need some ways to pull data or some tools that can help you pull data? Or what are some interventions that you might be interested in hearing about? Yeah. So hopefully you might be interested in screening tools or learning about specific screening tools for members. That is one of our plans, is to discuss that at our next session. We have one more minute and then I'll move on. Yes, thank you. Is this Kate or Sherilyn? So you would like to collaborate with others in your field and streamline your practice. I think that's a great idea.
Yeah, it sounds like folks have a lot of very creative solutions that they're already putting into place. Now, some of it obviously depends on having a lot more staff than some of you all have, but certainly there seems to be elements of what folks are currently doing that other people could adopt.
I think it would be important to highlight here, like best ways to form your community, to get those resources. You know, many people mentioned that connecting the patients to the outside resources, their mental health providers, is difficult. Even learning how to build up that community, I think, would be important in this group.
Definitely, and great point, Abby. And you know, that's something too, like as the QIO, we're really working to do, is to really develop these community coalitions or community collaborations in your area. We're across, you know, the different states that you're calling in from. We have communities in the different areas, and our hope is to really pull together all the different care settings that touch the patient along the way to develop some solutions, to develop maybe better communication tools, to understand where you can refer these patients to, you know, what community-based organization might be appropriate for the patient that we discussed during this presentation, and what other resources are out there. I'll welcome anyone else too from the QIO team to jump in on anything I might have missed there. Feel free to chat it in. And then my last question is actually, are there any questions from the presentation that we just did, from the series, where we're going? Any questions for us?
Can I ask a question, Stephanie? I'm curious if anyone is actually using some of the models that we discussed that are sort of published and more publicly known. I'm curious if folks have been able to implement models like that, or if you're developing your own sort of homegrown solution based on what you have around you.
Yep, you are correct.
So I can't tell if it's, I think it's Sherilyn this time. But she shares that these tools have been around a long time, and we blended them into our CCM model. And Diane shares health equity tools, since several of the issues for our presented patient had various needs.
Yeah, these tools have been around a long time. Makes sense to choose the elements that work for you.
And Sherilyn further shares that she used Indirect with the SNFs way back, and used warm handoff all the time to improve their transitions. And Amy also shares Interact.
Great. And Amy, are you still using Interact?
So I'm no longer working in the setting. I recently left, but yes, they are using Interact, and they don't employ the full Interact, but it's tools, and the Stop and Watch and the SBAR tools are very helpful, and the clinical pathways. are very helpful.
Sherilyn comments that COVID had interrupted a lot of this work, so very happy to revisit this topic.
We did. And I think Karen, I saw you come off mute.
Oh, yes. Excuse me. Yes. Thank you for sharing regarding Interact. And we just had a session yesterday regarding some of the Interact tools. And again, as you mentioned, COVID has, kind of taken over. So getting back to basics, and Interact does have some great tools on those pathways, as you mentioned. And it's really trying to catch those subtle changes before they necessitate a hospitalization, an exacerbation that has to go to the hospital. Requires that hospitalization. So again, learning and sharing with one another on what tools and resources work, I think is really great to see in the chat today. So thank you all for sharing.
Another comment, this is Amy, on the Interact tools. They're really helpful. We're all experiencing, staffing challenges. So when you're bringing in, agency that maybe you weren't using before, or you're onboarding new graduates. There are more new graduates in long-term care and in hospitals than we've seen historically. And those tools are really, really helpful when you're onboarding new staff.
I was just going to say something really similar, Amy, is that the effect of COVID can't be underestimated in terms of staff who would have been working on this being redeployed for other activities and now sort of circling back to it, and the fact that we have so many new staff in all levels of healthcare operations. It's really important, I think, to get back to basics and to take time to refocus and rethink what approaches that might have worked before COVID that may not be possible now.
Yeah, and I also think we underestimate the ability of meetings like this and opportunities like this to actually bring our staff back together and start thinking in a way that is going to be more rewarding than that burden that we've had over the last couple of years. So, I see these as opportunities to really recharge and put some energy back in to what we're doing. So it's great to see this going on.
Thank you so much, Amy. And we agree. We're very excited to be pulling everyone together and, really getting back to the basics, because as we know, things have changed and the tools that we've used before may not work as well. So what are some new solutions that we can develop going forward? But working as a community, I think, really working with the different care settings. We have all those different care settings represented on this call. And hopefully we'll have you join us throughout the series with more coming to join as well, so that we can share our learned experiences from each other, what's worked well, what hasn't worked well. So definitely encourage you to, reach out to us with any thoughts or ideas of what you want to hear about. And, we have a mighty team here that we can go and find those best practices and hopefully pull them in to present on some of the upcoming sessions.
Hey, Stephanie, we got a couple more comments in chat before we move on. So Sherilyn had shared that we have a diagnostic interview sheet that we could share for doing a deep dive on readmitted patients that guides the user to ask pertinent questions, and that they could send it to you.
Fantastic.
Esther also shares that with the staffing challenges and best practices as main focus, patient teachback and education to better understand what is prohibitive to patient successes are even more imperative. And lastly, Heather shared that we are just restarting meeting with our post-acute providers to review readmissions post-COVID. So Sherilyn, Stephanie also put her email into the chat, so make sure to grab that to be able to send over that diagnostic sheet over to her.
I just realized I spelled it wrong too.
Oh.
No, that's great. And that's great, Heather, to hear that you're restarting the meetings with your post-acute providers. That's something that we're definitely very interested in hearing about more as we go along. So, and let us know how that's going for you. Thank you, Josh. Are you experiencing any challenges with pulling that group together? And we can always assist as well.
Steph, can I also make an offer to the group where we do have Medicare fee-for-service data, and we're about to finalize. We have state reports on hospital readmission, hospital utilization, really. We have community so sets of zip codes. And we also have hospital reports, and the hope is to have those available by the end of the week. If you don't currently get one, if you would like one, please reach out to Stephanie. The updated email is in the chat. And we'll work with the local team member to make sure that you get a copy of that report. Steph, there was a comment about how to get the diagnostic worksheet. So the plan to share things that are shared.
Yes, so what I'll do is we'll have the list of those that have participated in this call. So I will email it out to all of you as long as I have the permission to do that from anyone who's sharing the documents. So we'll email that out. I'll also be emailing out a worksheet that we developed to help you dig a little deeper into your data to look at, 5 multi-visit patients and really determine, what brought them back to the ED. So I'll be sending that out. We'll send out a link as well to the registration for the upcoming sessions and also the PowerPoint from today. So that kind of led to our next steps. So, we'll encourage you to work on the assignment tool that we'll send out and share some key findings at our December 1st Learning Circle. We do realize this series has launched right at the beginning of the holiday season. So you'll see that it's going to be a little bit more spaced out to allow for that. Next week is Thanksgiving, which is insane to me. I don't know where the year went. And then of course we have Christmas coming up, or a holiday. So our next learning circle, that will be just 30 minutes, is going to be more of this open forum type situation where you can, talk about your challenges or even your successes and digging in. And also if you need any additional information at that time, kind of think of it as an office hours. And then December 15th will be our next bigger session, and this will be looking at specific screening tools, referrals, and really closing that data loop. And we do have a complex care compendium, which highlights some best practices and models. So definitely check it out. It's a nice little sheet where it has some information all in one place for you. So I did want to make sure to share that link here. And I just want to make sure I didn't miss anything in chat. All right. Well, if there are no other questions, we can definitely give you 10 minutes back in your day. So hopefully you can finish up that lunch and get ready for the rest of your Wednesday. Thank you, everyone. Thank you, Dr. Gardner, for a wonderful talk today. It was great seeing everyone, and we're looking forward to seeing you in our next sessions.